it's a great honour to speak to such an international group of patients who have such a common interest, which is how they can live with a prostate cancer that they know now tends to progress very slowly and far more likely to die from heart attacks or strokes than from their prostate cancer. But there's always that uncertainty in patients on active surveillance. And uncertainty is that, have they been mischaracterized? Has their disease been mischaracterized? I mean, the talk that Ferd gave about the fact that they mixed up his MRI scan and he thought he had locally advanced or, metastatic prostate cancer, as bad as that. And in fact, he didn't. And here, 12 years later, he's living well. And you, Howard, living comfortably on active surveillance. And all of you doing so. But there will be people who will continue to be concerned and worried, because active surveillance requires trust, and it requires trust of your surgeon, and it requires trust in the investigations that have been done. And that's one of the things that, for me personally, as a surgeon, where I operate on people and I do brachytherapy and I do biopsies, I want to try to resolve the uncertainty so that patients will be able to make the appropriate decision with the best information available to them. And when I started in practice back in 96, 97 as a consultant, the only option we had was transrectal biopsy, standard radiotherapy, and open radical prostatectomy. There were no other choices, and people didn't really go for active surveillance. It was really something that wasn't even discussed. So I do have some disclosures of relevance to this talk. Now, it remains worldwide that the current prostate cancer diagnostic pathway is that you have a PSA blood test done, and the PSA blood test is elevated. You then visit your doctor's office, and he will then carry out a rectal evaluation of the prostate gland, and then will probably make a recommendation if the PSA is abnormal and the rectal examination is abnormal, or even if it's normal, that you should have a transrectal biopsy. And the problem with the transrectal biopsy, as you can see in the bottom picture, is the transrectal biopsy samples the posterior portion of the prostate very well. But the anterior portion of the prostate, which is the little bit I've outlined in blue, is actually very difficult to approach transrectally. So it's a sort of a blind spot when you're driving down a motorway. Oh no, we call them motorways, but a freeway. You get a blind spot, and there's a lorry coming up your blind spot, and you never even saw him, and you were just about to pull out, and what's going to happen? Well, you're going to end up in a big crash. That is the problem. My colleague Tim O'Brien in my hospital, who's now president of the British Association of Urological Surgeons, coined the term transfecal prostate biopsy, because the truth is, it is. And, here, one can imagine sitting there and the doctor's telling you that you need to have this biopsy, and I'm going to put this probe in your back passage, and I'm going to take some biopsies through your back passage into your prostate, because that's the easiest way that I can approach it, and that's the best way of doing it. But transrectal, transfecal prostate biopsy, you have to understand, the rectum is a dirty box. The prostate is a clean box. And the problem is because those two things do not go together well, that there is a risk of sepsis. Now, 15 years ago or more, when I did my first transrectal biopsies, we didn't use local anesthetic. We rarely gave antibiotics. You just did it. And then when I started doing the antibiotic, we started seeing patients with sepsis. We started introducing various types of antibiotics, an antibiotic into a vein, an antibiotic into the back passage, and then some tablets to go home with. So as long as you gave them the antibiotics, everything was fine. But that was 20 years ago. And we all know that bacteria and these organisms and viruses have this incredible ability to move out of the way of the thing that's coming along to stop them. And that is a problem. And it really does not matter. Even if you use the highest quality antibiotics and the highest quality antibiotic surveillance in order to try and identify the correct antibiotics that you should give. And you can take swabs of the back passage and say, okay, we've got this organism, we know it's sensitive to this antibiotic, so we'll make sure we give them this antibiotic. And anyway, it's twice as expensive as the old antibiotic, so it's got to be better. Well, it isn't always. And the problem is even in the best hands, you cannot eradicate sepsis related to transrectal biopsies. And whatever way you count the numbers, we talk about 1 to 3%. It is rare, but it's always, even in the best hands, even the people who say, well, my sepsis rate is only 0.5%. Well, that is 1 in every 200 patients. And you think how many patients are having a transrectal biopsy worldwide. And it's certainly a lot of patients. We're going to be talking about the experience of a lady and her father, who tragically died of a septic embolus. And it wasn't actually sick. I've got here 6 days post transrectal biopsy. It was only within 3 days. This was a fit man and he died. And she wanted to know why. And because she'd been helped by her own urologist, and I'm sure they'll give you more of the story in detail, which makes my skin crawl every time I hear it. But what they did was the Norwegians, they went back and looked at resistance to antibiotics that they had documented previously to one antibiotic, trimethoprim, and another antibiotic, ciprofloxacin. And what they found was that the infection, the resistance rates to antibiotics had increased dramatically. And they also found that 10% of all patients having their biopsies underwent a hospitalization within 60 days of a biopsy. And they are changing their practice because they've been forced to. I had a patient who was a charming gentleman, and I remember speaking to him about his life, and he'd been a very successful man, and he was in his 50s. He's younger than I am now. And he'd made his money. He'd had his children young. They were all happy. He was happy. And the thing that he enjoyed more than anything was walking up mountains. He was a climber, but he just basically just loved going up mountains. And in Europe, in Switzerland and Norway, we have these mountains and the most beautiful views. And what he gave his life to in his retirement was to actually climb and walk up to all these mountains and enjoy his life. But there was a problem, and the problem was that he had an elevated PSA blood test. Now, because he had the PSA blood test that was elevated, he came to me and I sat him down and I said, well, there's a possibility you might have prostate cancer. That's why your blood test is raised. So we discussed it and we discussed the risks. And I told him there's a risk that you get infection, but I'll do my utmost to make sure everything's okay. And he trusted me. He trusted me with his life. As it happened, he didn't lose his life, but he came very, very close to losing his life. And that was in 2005. So I did the transrectal biopsies. I gave him the appropriate antibiotics, and we didn't find that he had any cancer, but he developed life-threatening sepsis, ended up on the intensive care unit, diabetic, renal failure, ended up on dialysis, and he never climbed a mountain again in his life, but he still thanked me because I hadn't found any cancer. Now, for me, I was just blown away by the experience of managing this patient because I'd lived every day he was sick. And so in 2006, I'd already been doing transperineal procedures because we'd started doing prostate brachytherapy. So I had an idea about the perineum and I operated on prostates. And I said, right, we are not going to go forward with any transrectal biopsy in our patients. And I was fortunate, I was the senior consultant, I was in charge of the department. I just said, no, it has to stop. but we couldn't translate all of our biopsies to transperineal. That wasn't possible, but we set some guidelines, and we said any patient that was at risk of sepsis, so that would be diabetics, people who'd had a previous urinary infection, people who'd had a large prostate with symptoms, which is what my patient had, patients who'd had antibiotics, or they traveled to Asia or Africa where you can pick up very funny organisms in your bowel, they would not get a transrectal biopsy. They would move to a transperineal biopsy. The other thing we said was any patient who was thought to be suitable for active surveillance based upon a transrectal biopsy should have a transperineal biopsy to confirm that they were suitable for active surveillance. And any patient who'd had a previous transrectal biopsy in whom the biopsy was negative, big relief. No cancer, my biopsy's clear. The doctor says I'm absolutely fine. But then a year later, the PSA's doubled and the PSA's gone up. And then you're back in the office and the doctor says, well, your biopsy was fine last year, but we better check again. Well, I said, right, nobody gets a second transrectal biopsy. They got away with it once. Howard, you've got away with it 6 times. I don't know how, but they got away with it once. All of our patients will be offered a transperineal biopsy. Now, they may not choose to have that transperineal biopsy, but they were offered it. And any patient where they had had an MRI scan, where there was an obvious anterior abnormality, we would make sure that we took targeted biopsies, and also it became patient choice. Now, when I started doing this, what we found was 36% of all patients who'd had a previous negative biopsy, actually, we found cancer. And all of those patients chose definitive treatment because their cancer had been missed by their first biopsy. So they didn't, even if they were suitable for active surveillance, they wanted treatment. 37% of patients who we thought were suitable for active surveillance based upon their initial biopsy actually had higher grade or volume of disease, and we were able to offer them early definitive treatment, curative treatment, because they needed it. And where we did this transperineal biopsy as a primary biopsy, and remember, this approach predated the use of MRI scan up front before biopsy, which is what we do now, we were identifying cancer in 63% of the patients, and 15% of them had disease exclusively in the anterior sectors. And it's very reassuring to me that Richard Szabo, in his review of all this evidence over the last 10 years, it's all the same. Transperineal biopsy picks up more cancer. But the problem is many people who don't believe it say, well, it picks up more cancer because you do more biopsies. You're taking more specimens, so you pick up more cancer. And that may be true to a degree, but it's not true for everybody. And the most important thing, and this is the reason why the European Association of Urology have now declared in their guidance that the recommendation for prostate biopsies should be transperineal. What they haven't said is how that should be done, but they've made that recommendation, not because transperineal biopsy is a better, safer biopsy, as Richard said. They've made that recommendation because of the potential risk for sepsis. And the fact is, in Europe, they have virtually banned the use of a particular type of antibiotic called quinolones, which people might know as ciprofloxacin or ofloxacin. And these antibiotics are the ones that stop sepsis in transrectal biopsies. So if you say you can't take that antibiotic, you actually increase your risk of sepsis considerably. And that is a real problem. Now, when we did these biopsies, we had no sepsis and we had minimal complications. And so I was very happy with this approach, but we carried on doing transrectal biopsies in patients. And it was by about 2012, we were about 50% transperineal, 50% transrectal biopsies. And myself and a colleague have looked at all the biopsies done over the last 5 years, since 2012 in the UK. And we've looked at the data that's come out from the NHS. And in between 2012 and 2016, about 17% of all biopsies were transperineal. By 2017 to 2019, this had increased to 33% of all biopsies are transperineal. And that is quite a lot of biopsies in the UK. It's over 100,000 biopsies. But that still means that 400,000 biopsies were being done transrectally. Now, this is quite recent data, and this graph shows in the sort of the reddish color to the left of the screen are those hospital trusts. These are hospitals in the UK that are doing transperineal biopsies, and the hospitals in the UK that are still doing transrectal biopsies. Now, some of these hospitals will be double counted because many of them will do some transperineal and some transrectal. But you can see that the majority of the burden of sepsis is firmly in those hospitals that do predominantly transrectal biopsies. And this is data from 2017 to 2019. When we get data from 2019 to 2020, this change will be even greater. And when we get the data from 2020 to 2021, which is in through COVID, I think we'll find actually our sepsis rates go down because we're doing less transrectal biopsies in COVID and we're doing more transperineal biopsies. So this is data that I'm very keen that we get soon, and hopefully at some stage I may be able to share it with you. Now in the UK, nobody gets a prostate biopsy without having an MRI scan. And in some ways that makes it very easy, because if they've got an obvious cancer, then you can take a biopsy from that area using various techniques. If only just looking at saying, okay, well, that's the side that looks abnormal, so we'll take some biopsies there. And that's very, very effective. And you can use that to reduce the number of biopsies that you do. And therefore, people say, well, you can do that and you can use transrectal biopsies. You don't need as many biopsies, but you will still have some sepsis. And you cannot avoid the sepsis. It will still be there. It will never go away. Now, why don't we do transperineal biopsies for everybody? I'm sorry, I don't know why my slide went away, but I hope you got it back. We don't do transperineal biopsies for everybody because most of transperineal biopsies require a general anesthetic, and it generates waiting lists and delays to the pathway of treatment. And you can do these biopsies under local anesthetic, but as you can see, it's the same equipment, the patient, everything's being held out there. And I would call this tolerable, not comfortable. Now, until I was introduced to this device, which is the device invented by Matt Alloway, who's a urologist. And when I saw this device, I realized for the first time that I could do a transperineal biopsy effectively to sample areas of abnormality in the prostate and do biopsies of the rest of the prostate under local anesthetic, because I wanted to be evaluate. This is sort of diagram shows a prostate gland, and that's a lesion on one side of it. And I wanted to be able to identify cancer in the lesion, but also do some biopsies elsewhere. But I'd like to be able to do that under local anesthetic in the outpatients. Now, this little video shows you what we can do
in decades, and it's all down to this. It's called the PrecisionPoint Transperineal Access System, and it's revolutionizing biopsy procedures.
Hello, Paul. Okay, so what we're just going to do is just run through briefly what we're going to do inside the operating theatre. My name's Rick Popert. I'm a urologist, but I've had an interest in prostate biopsies for many years. I became offended by the principle of transrectal biopsies over 12 years ago when we had patients who had significant sepsis.
Transrectal biopsies have been the standard technique for over 30 years, but they risk infection and false negative results. Rick Popert then moved to transperineal biopsies, but needing a general anesthetic, it's resource heavy and expensive. Now all that has changed.
Little scratch on the skin, right? Little scratch. I then use some local anesthetic to inject into the skin.
The new PrecisionPoint device is attached to the ultrasound probe, and it's used to guide the anesthetic needle to the prostate.
And then we put a deeper injection up towards the two sides of the prostate. Here comes the needle now. little uncomfortable. Very good. And then we're just injecting the local anaesthetic then. Perfect. So that's one side done. And now we've just got to do the same thing just on the other side as well. A little uncomfortable now. There's the injection going in there. It's already numb. Okay? So you happy for me to take the biopsies? Good. All right? Yeah, absolutely fine. So you feel a bit of pressure now, and you're going to feel just a little bit more just pressure, just as I pop the needle towards the prostate. Was that painful, or was it just the pressure? Pressure, yeah. Okay. Not painful at all. You'll hear the sound of the biopsy gun going off, which sounds a bit like an air gun. And you may get a feeling just a sort of little jump. This sort of area is impossible to really target accurately with the standard biopsy. So this is why this is a better biopsy, really. And now I'm just going to walk my way across the top of the prostate.
I wouldn't say it was pleasant, but it's nowhere near as bad as I anticipated, to be perfectly honest with you. The idea behind it is fiendishly simple and elegant.
So it's the movement of the probe up and down, which tilts the prostate to meet the biopsy needle, which allows you to use one puncture.
No pain whatsoever.
It's revolutionised our practice. It's allowed us to do more of our transperineal biopsies under local anaesthetic in the outpatients than we've ever been able to do. It allows us to reduce the need for general anaesthesia such that the majority of patients can be done under pure local anaesthetic and some with a small amount of sedation if necessary. But the beauty of this thing is that I'm only making 2 punctures just in the skin, and yet I'm taking 27 biopsies in total.
No words. It's very quick. For a very, very thorough. I could see how thorough that was.
And once the procedure's done, we just check your blood pressure, sit you up, and hopefully walk you out a cup of tea, and then home once you've passed some urine. I suspect that Norway will probably beat us to abolishing transrectal biopsy, but I hope that we won't be far behind. The TRexit initiative, which we established at my hospital, has now expanded across the South East London Cancer Network, which is a population of 1.5 million. We stopped all biopsies transrectally there in March 2019. Around the UK, between June 28 up to June 2018, there were only 12 centres doing biopsies using the transperineal system, but that was within 6 months of us achieving the CE mark. By December 2019, over 70 centres were routinely using it. And then, of course, we had the pandemic. And it's interesting, the pandemic has driven people to do biopsies under local anaesthetic in the outpatients because they don't have access to general anaesthetic operating lists to do their standard transperineal biopsies. So they're falling over themselves to learn the techniques that we've developed along with Matt Alloway. And I think in some ways the challenges of COVID are the opportunity that we're grasping now, because we've now got over 140 hospitals in the UK that are routinely using local anaesthetic transperineal biopsies. And that's not just with the PrecisionPoint system. There are other systems that are available. And people are realizing that transrectal biopsies are just not worth it. So I believe that a local anaesthetic transperineal biopsy is a better, safer biopsy, and it is fit for a COVID future. And the time is for TRexit. And that, I believe, is the most important contribution that the modern science can make to urology. It's far better than MRI scans or anything. Why, as a urologist, would you push something through the rectum into something that is clean? My old colleagues never would have imagined doing transrectal biopsies. They all did them transperineally, and it wasn't until we'd invented the ultrasound, and it's interesting that transrectal ultrasound was developed in the Scandinavian countries, and it was from there that transrectal biopsy started. And yet it's the Scandinavian countries that are leading part of this move away from transrectal biopsies. So I hope you've enjoyed the talk. I think what you're doing as a group is absolutely fantastic. Take up the opportunity and insist in your active surveillance that you must have an MRI scan, because that may identify a lesion that looks abnormal. And also do not accept a transrectal biopsy if there's an opportunity to get a transperineal biopsy. Thank you for your attention.